Yeah, so we are starting with part 2 of the stomach. In the previous class, we had discussed about peptic ulcer disease of stomach, which includes both gastric ulcer as well as duodenal ulcer and its management. So, in today's class, we'll be dealing with some specific pathologies related to stomach, mainly upper GI bleeding, then some bleeding disorders of stomach. After that, we'll deal with carcinoma of stomach, which is most important in this class. After that, we'll see some disorders like congenital hypertrophic pyloric stenosis and gastric volvulus, which are mentioned in your curriculum. Okay, so starting with upper GI bleeding. So, what is the most common cause of upper GI bleeding? It is the peptic ulcer, which we had discussed in previous class. And as we all know, what is the primary investigation we'll do in case of peptic ulcer or upper GI bleeding? We'll go for endoscopy and see actually from where the bleed is happening. So, hence, endoscopy is the first investigation in case of upper GI bleeding. So, there are certain risk stratification systems we use to identify and to assess the risk of upper GI bleeding, if it is a major bleeding or if it is not. For that, we use certain stratification systems. So, most commonly used scoring systems are Rockall-Baylor score and Blatchford score, which are these are not necessary. Just know how we will classify or how we will assess which is major and which is minor. Okay, in case of Rockall and Baylor score, we can use the mnemonic CASDE. Okay, so that is if the patient is having any comorbid disease, like it may be related to heart, liver, kidney, or related to some blood vessels or disseminated diseases. Okay, then that will be adding to the risk. Other than that, if age is less than 60 years, or if it is 60 to 79 or more than 80, based on this again we'll give a score. Again, shock, if the BP, if the patient has presented with upper GI bleeding, or if the patient has come with complaints of vomiting of blood or something, so and you measure vitals, and if the BP is less than 100 mmHg, then it is more risk. If there is tachycardia, that means the body is trying to compensate for the loss, hence heart is beating faster. So heart rate is more than 100 beats per minute, then these two will add a score. Other than that, diagnosis at the time of endoscopy, like Mallory Weiss tear or non-malignant lesions or malignant lesions, this will again carry a score. Other than that, it can be endoscopic stigmata of the recent bleed. Okay, so these C, A, S and D, comorbid disease, age, shock, diagnosis at the time of endoscopy, and endoscopic stigmata. These are used as parameters for stratifying upper GI bleeding, and that score is called as Rockall-Baylor score. In case of Blatchford score, what we'll use is we'll use pulse, blood urea nitrogen, that is BUN, then systolic BP, hemoglobin, presence of melena, syncope, hepatic or cardiac dysfunction. Basically almost all are same, but the order is disarranged. Okay, so you can remember this as push melena or push MSH, something like that. Push stands for P for pulse, U for urea nitrogen, S for systolic BP, H for hemoglobin, and rest is melena, syncope or hepatic or cardiac dysfunction. So this was about Blatchford score. These two scores are used. Suppose you give one point score. Okay, so 1 plus 1 plus 1 plus 1, and again for melena syncope this 1 point. So overall out of 5, if it is more than 3 or 2 or some score will be assigned, and based on that we can say it is major or minor. Basically like that we'll assess. Okay, then bleed risk classification. So this is used to predict the risk of rebleeding and mortality in patients of upper GI bleeding. Okay, if what is the chance that this bleeding can happen again, or what is the chance that the patient might die because of this upper GI bleeding, that is called as bleed risk classification. So based on the following criteria, if the currently if the bleeding is ongoing, if the systolic blood pressure is low, if the prothrombin time is elevated, and mental status is not or there is impaired mental status, and there is history of any unstable comorbid disease, then all these factors will influence, and we can predict if there is if there is a chance of rebleeding or mortality in case of upper GI bleeding. Similarly, there is one more classification called forest classification, which is again used for rebleeding estimation. Okay, if uh, uh, under that 1A, 1B, 2A, and 2B, we are classifying 2A, 2B, 2C, and 3. Okay, these are the classification systems. So 1A stands for active pulsatile bleeding. 1B is active. Along with that, there is oozing, continuous blood is pushed out. Okay, so 2A is non-bleeding but vessel is visible. So all these three is classified as high risk of rebleeding. Okay, so 2B is adherent clot is there and there is intermittent risk of bleeding. Okay, then 2C is black dot. You can just see, basically you are doing endoscopy. Okay, while doing endoscopy, if you are able to see active bleeding, so suppose this is stomach or esophagus, then stomach. Okay, so you are doing endoscopy. While doing endoscopy, if you are able to see active bleeding like this from here, then that is 1A. If the blood is oozing continuously, then that is 1B. If there is a vessel visible but it is not bleeding now, that is 2A. Okay, so you are able to see a vessel but it's not bleeding like this. Okay, and if there is a clot present within the vessel, so it is intermittent risk, because whenever you will never know when a clot will get lysed and again it will start bleeding. So if there is a adherent clot, it is intermittent risk of bleeding. If there is 2C, there is just black dot visible and while doing endoscopy, and this is classified as 2C. This can be a clot or it can be enlarged blood vessel or a blood vessel at risk of bleeding. So there is always a low risk of bleeding when you see a black dot over on endoscopy. Okay, if there is clean base also, again there is a low risk for bleeding. So this is forest classification based on endoscopic findings. Okay, so basically for upper GI bleeding, we are using following scoring systems: Blatchford and Rockall and Baylor scores. This is used for classifying the risk stratification in case of upper GI bleeding. And for bleed risk classification, if there is a chance of rebleeding, for that we have studied two risk classification systems, that is bleed risk classification and forest classification. Okay, so after this we are starting with some of the bleeding disorders of stomach. So what are those? First one is Mallory-Weiss syndrome. Mallory-Weiss syndrome, just like I had explained in the previous class also, this is characterized by longitudinal partial tear. That is, submucosa and mucosa is involved and there is a longitudinal tear. Just like we are seeing here, there is a longitudinal tear, there is a longitudinal tear here. So, longitudinal tear is there in the mucosa and submucosa of the stomach. Why is this happening? Because of repeated vomiting and forceful vomiting along with retching. Okay, so because of repeated forceful vomiting, there is a tear in the submucosa and mucosa. Why is this repeated vomiting or forceful vomiting happening? It is usually seen in case of alcoholic males and in the junction of gastroesophagus junction or cardia. Okay, so because of suppose alcoholic males are there, because of that there is repeated vomiting and forceful vomiting and retching, and because of this there will be a tear in the gastroesophageal junction of cardia region of stomach, and also it can happen in esophagus also. So what will be the clinical feature? Because of this forceful or longitudinal tear, there can be bleeding. Usually the bleeding will be minor, so majority of the cases there will be minor bleeding, but there can be massive bleeding in case of in 10 to 20% of cases, and it is usually painless, so patient won't come to us immediately. Okay, even if they see slight amount of blood in whatever the vomit they are doing, they won't come to us because it is painless. Only if there is pain they'll immediately rush to hospitals. So you should remember this: painless condition and there will be minor bleeding, but there can be major bleeding in 10 to 20% of cases. And what is the most common vessel responsible for bleeding? That is left gastric artery. Okay, so why is left gastric artery most common? Because we all know, while studying liver also we had studied about celiac trunk. From there three main arteries come one along the lesser curvature of the stomach, this was small or left gastric artery. Okay, other one was gastroduodenal or hepatic artery, common hepatic artery that will go and divide into right gastric and left gastric, and the other one was gastroduodenal artery. Okay, so left gastric artery, this runs along the lesser curvature of the stomach, and since malarial tear is happening here in the cardia region, the vessel supplying there is the left gastric artery, hence it is the most common. So here what you need to remember, main or the most important point you should remember is, in case of portal hypertension or variceal bleed, we'll say Allah, the bleed which is happening from veins, whereas here in case of Mallory-Weiss syndrome, whatever the bleed is happening, this is from artery. So arterial bleed ಗೂ venous bleed ಗೂ difference ಇದೆ. Veins can be compressed or it can be collapsed, but arteries cannot be compressed, and pressure will be more from arterial blood. Fresh bleeding ಇರುತ್ತೆ, pressure ಜಾಸ್ತಿ ಇರುತ್ತೆ, ooze out ಆಗ್ತಾ ಇರುತ್ತೆ. With every pulse blood will be spilling out. Veins ಹಂಗಲ್ಲ, if you put pressure they'll get collapsed. Okay, so this is a major difference. ಸೊ ಹೆನ್ಸ್ ಮ್ಯಾನೇಜ್ಮೆಂಟ್ ವಿಲ್ ಡಿಫರ್. ಅಲ್ಲಿ ಏನು ಮಾಡ್ತಿದ್ವಿ, ಈಸೋಫೇಜಿಯಲ್ ವೆರಿಸಸ್ ಪೇಷಂಟ್ ಬಂದರೆ ವಿ ಯೂಸ್ ಟು ಡೂ ಎಂಡೋಸ್ಕೋಪಿ ಆ್ಯಂಡ್ ವಿ ಯೂಸ್ ಟು ಸಿ ಇಫ್ ವಿ ಕ್ಯಾನ್ ಡೂ ಎಂಡೋಸ್ಕೋಪಿಕ್ ಲೈಗೇಷನ್ ಆರ್ ಬ್ಯಾಂಡಿಂಗ್. ಇಫ್ ನಾಟ್ ಪಾಸಿಬಲ್ ದೆನ್ ವಿಲ್ ಗೋ ಫಾರ್ ligation of the primary vessel, or if not possible we can put Sengstaken Blakemore tube also, which is like a balloon this thing which can put pressure over the esophageal veins, and then we used to transport him from some rural facility to higher facility ಈ ಥರ. ಕರೆಕ್ಟಾ? Because that was a venous bleeding, but here Mallory-Weiss syndrome is an arterial bleeding, so you can't do that. You have to ligate the artery. Okay, so how will we diagnose? Diagnosis is again based on endoscopy. What is the management? Conservative management basically, because usually it will be minor bleeding only. So if this minor bleeding is not controlled, then we'll have to go for endoscopy and electrocoagulation, that is cautery. Okay, even if on cauterization it is not if the bleeding is still continuing, then we will have to go for angiography, look from where the bleeding is actually happening, and we will have to go for embolization. If even after this the bleeding has not stopped, then we will have to go for open surgical ligation of the bleeding vessel. Okay, so this is the management steps. First we will see if the bleeding will stop on its own. If it is not stopping, then we'll have to go for cauterization. If it's not stopping even after cauterization, then we'll have to go for angiography and embolization. If it is not stopping even after this, then we'll have to go for open surgical ligation of the bleeding vessel. Okay, so yeah, the point which I mentioned just before you, that is Sengstaken Blakemore tube, which was a tube with balloon at the end, just like this. Imagine like this. Okay, so by putting fluid we used to inflate this. Okay, this use is indicated in variceal bleeding, that is portal hypertension or something like that. But in case of Mallory-Weiss syndrome, this is contraindicated because this is not a venous bleed, it is an arterial bleed. Arterial bleed won't stop if you compress this. So Sengstaken Blakemore tube use is contraindicated in case of Mallory-Weiss syndrome. Okay, next bleeding disorder of stomach is called as Dieulafoy's lesion. So what is different here? There is presence of a large arteriole below the mucosa with diameter of about 1 to 3 mm. So what you are able to see here, which is a bit dilated snake-like structure running along the mucosa of the stomach, that is a enlarged arteriole. Okay, so usually this will be seen about 6 to 10 centimeters of gastroesophageal junction near the lesser curvature. So what happens here is the mucosa is getting constant pressure from this enlarged arteriole. So whatever the arteriole is there, that is putting pressure over the mucosa. Because of that, the mucosa will lose its blood supply. If there is loss of blood supply, the mucosal tissue will undergo death, that is necrosis. So there will be necrosis of the overlying mucosa, because of which now mucosa was a preventive layer. It was preventing arteriole from getting exposed to stomach acid, whatever the acid is there, HCl. Okay, so HCl, then mucosa, within that was the arteriole. Now, since the mucosa is undergoing necrosis, there is no one preventing the arteriole from getting exposed to hydrochloric acid of the stomach, because of which there will be injury to the wall of the arteriole. So, hence, if the wall of the arteriole gets damaged, what is flowing inside the arteriole? That is blood. So, there will be active, and since it is an artery, there will be pulsatile bleeding. Hence, there is increased risk of rebleeding even if you cauterize it. Again, the arteriole wall is damaged, because of which again the acid will cause damage to the arteriole, and again there will be rebleeding. So risk of rebleeding is more in case of Dolufoy's lesion. Okay, so based on this, what will be the clinical features? Again, massive bleeding will be there. Whatever the blood is coming, that will be getting into the stomach, and that will be exchanged or put out in the form of blood vomitus, that is hematemesis. And usually, since the blood is lost in vomit, there will be hypotension, that is shock. ಹೈಪೋವೊಲಿಮಿಯಾ ಆಗುತ್ತಲ್ಲ, ಹೈಪೋವೊಲಿಮಿಯಾ ಆದರೆ ಏನಾಗುತ್ತೆ, ಬಿ ಪಿ ಡ್ರಾಪ್ ಆಗುತ್ತೆ. ಸೊ ರಿಕರೆಂಟಾಗಿ ಹೈಪೋಟೆನ್ಷನ್ ಆಗ್ತಿರುತ್ತೆ. ಅವ್ನು ವಾಮಿಟ್ ಮಾಡ್ತಾನೆ, ಹೈಪೋಟೆನ್ಷನ್ ಆಗುತ್ತೆ. ಮತ್ತು ನೀವು ಫ್ಲೂಯಿಡ್ಸ್ ಕೊಟ್ಟು ಏನೋ ಮಾಡಿ ಮ್ಯಾನೇಜ್ ಮಾಡ್ತೀವಿ, ಮತ್ತೆ ವಾಮಿಟ್ ಆಗುತ್ತೆ, ಮತ್ತೆ ಹೈಪೋಟೆನ್ಷನ್ ಆಗುತ್ತೆ. ಸೊ ರಿಕರೆಂಟ್ ಹೈಪೋಟೆನ್ಷನ್ ಆ್ಯಂಡ್ ಹೆಮಟಮೆಸಿಸ್ ಆರ್ ದ ಕ್ಲಿನಿಕಲ್ ಫೀಚರ್ಸ್ ಯೂಶುವಲಿ. How will we diagnose it? Again, in order to see this enlarged arteriole, we will have to go for endoscopy. So how will we manage? Endoscopically, electrocoagulation if available. Primarily, the first step is to stop bleeding. For that reason, we are going for endoscopic electrocoagulation. If again bleeding is not stopping, again go for angiography and embolization. Again, if it doesn't stop even after that, we'll go for surgical ligation of the bleeding vessel, or we'll have to resect the part of the stomach from where the bleeding is actually happening and make sure that it contains arteriole also. So this was about Dolufoy's lesion. So we have discussed two main pathologies in bleeding disorders of stomach. One was Mallory-Weiss syndrome, other one is Dolufoy's lesion. Now third one is watermelon stomach. Because of appearance of stomach like a watermelon, you can see this is red, alternatively red patches are there, which is appearing like a watermelon. So hence it is called as watermelon stomach, but actually it can be called as gastric antral vascular ectasia. Gastric ಅಂದರೆ ಸ್ಟಮಕ್, ಆಂಟ್ರಮ್ ರೀಜನ್ನಲ್ಲಿ ವೆಸಲ್ಸ್ ಡೈರೆಕ್ಟ್ ಆಗಿದೆ, ದಟ್ ಈಸ್ ಎಕ್ಟೇಸಿಯಾ. ಸೊ ಮೋಸ್ಟ್ ಕಾಮನ್ ಸೈಟಲ್ಲಿದೆ, ಜಸ್ಟ್ ಲೈಕ್ ದ ನೇಮ್ ಸಜೆಸ್ಟ್, ಗ್ಯಾಸ್ಟ್ರಿಕ್ ಆಂಟ್ರಮ್. ಏನಾಗ್ತಾ ಇದೆ ಪ್ಯಾಥಾಲಜಿ? ವ್ಯಾಸ್ಕ್ಯುಲರ್ ಎಕ್ಟೇಸಿಯಾ, ಅಂದರೆ ಬ್ಲಡ್ ವೆಸಲ್ಸು ಇಷ್ಟಿಷ್ಟೇ ಇರಬೇಕಿತ್ತು, ಇಲ್ಲಿ ಏನಾಗಿದೆ, ಬ್ಲಡ್ ವೆಸಲ್ಸ್ ಹ್ಯಾವ್ ಬಿಕಮ್ ಡೈಲೇಟೆಡ್ ಆರ್ ಎನ್ಲಾರ್ಜ್ಡ್. In the gastric antrum region, the blood vessels are enlarged. That pathology is called as gastric antral vascular ectasia, and since these blood vessels dilated appear like a watermelon, it is called as watermelon stomach. So usually it is more commonly seen in elderly females, and there will be chronic occult bleeding, because of which there will be dilatation of these blood vessels. And since there is chronic bleeding, the patient will be losing blood, but we won't be knowing, because of which there will be anemia. And because of anemia, the patient will be having fatigue, and this is usually associated with chronic liver disease in case of 25% of females. Okay, so how will we diagnose it? Again, diagnosis is based on endoscopy. If on endoscopy, if it is appearing classically like a watermelon stomach, we can easily diagnose. If it's not, then we'll have to go for biopsy and see if the if the blood vessels are actually dilated. If there are parallel stripes of dilated blood vessels near antrum on endoscopy, then we can easily diagnose it as watermelon stomach. So what is the treatment? Again, endoscopic electrocoagulation. Bleeding ಆಗ್ತಾ ಇದೆಯಾ, ಬ್ಲೀಡಿಂಗ್ ನಿಲ್ಲಿಸೋದಷ್ಟೇ, ಇದಕ್ಕೆ ಬೇರೆ ಏನು ಟ್ರೀಟ್ಮೆಂಟ್ ಇಲ್ಲ. Okay, so these were the bleeding disorders of stomach. Under bleeding disorders of stomach, we discussed three main pathologies. Mallory-Weiss syndrome, Dolufoy's lesion, watermelon stomach, or this can be called as gastric antral vascular ectasia. ಓಕೆನಾ? ಸೊ ಮೂರಿಂದ ನಮಗೆ ತಿಳಿದಿದ್ದೇನು ಅಂದರೆ, ಮೋಸ್ಟ್ ಕಾಮನ್ ಸಿಂಪ್ಟಮ್ಸ್ ಆರ್ ಅಪ್ಪರ್ ಜಿ ಐ ಬ್ಲೀಡಿಂಗ್, ಇಟ್ ಕ್ಯಾನ್ ಬಿ ಹೆಮಟಮೆಸಿಸ್, and it can be fatigue, vomiting, ಈ ಥರದ್ದು. ಓಕೆ, ಸೊ ಕ್ಲಿನಿಕಲ್ ಫೀಚರ್ಸ್ ಆಯಿತು. ಡಯಾಗ್ನೋಸಿಸ್ ಎಲ್ಲದಕ್ಕೂ ವಿ ಯೂಸ್ ಎಂಡೋಸ್ಕೋಪಿ ಆ್ಯಂಡ್ ಮ್ಯಾನೇಜ್ಮೆಂಟ್ ಇಸ್ ಆಲ್ಸೋ ಸೇಮ್. ಎಂಡೋಸ್ಕೋಪಿ ಮಾಡಿ ಕಾಟ್ರಿ ಮಾಡ್ತೀವಿ. ಅದಕ್ಕೂ ನಿಲ್ಲಿಲ್ಲ ಅಂದರೆ ವಿಲ್ ಹ್ಯಾವ್ ಟು ಗೋ ಫಾರ್ ಆಂಜಿಯೋಗ್ರಫಿ ಆ್ಯಂಡ್ ಎಂಬೋಲೈಸೇಷನ್. ಇದಕ್ಕೂ ನಿಲ್ತಿಲ್ಲ ಅಂದರೆ ವಿಲ್ ಹ್ಯಾವ್ ಟು ಗೋ ಫಾರ್ ಓಪನ್ ಸರ್ಜಿಕಲ್ ಲೈಗೇಷನ್. Okay, so this was briefing summary of bleeding disorders of stomach. Okay, now we'll start with the most important topic of stomach, that is CS stomach. So CS stomach can be of two varieties. One adenocarcinoma, which is the most common variety. Other one, it can be squamous cell. Okay, so most common variety is this thing, adenocarcinoma, that is a carcinoma which is arising from the glands, hence the name adeno. Adeno ಅಂದರೆ ಗ್ಲ್ಯಾಂಡ್ಸ್. ಸೊ ಗ್ಲ್ಯಾಂಡ್ಸಿಂದ ಬರೋ ಕಾರ್ಸಿನೋಮಾ, ಗ್ಲ್ಯಾಂಡ್ಸಿಂದ ಬರೋ ಟ್ಯೂಮರ್ ಅಷ್ಟೇ. ಇಟ್ ಈಸ್ ಮೋಸ್ಟ್ ಕಾಮನ್ಲಿ ಸೀನ್ ಇನ್ ಲೋ ಸೋಷಿಯೋ ಎಕನಾಮಿಕ್ ಸ್ಟೇಟಸ್. ಓಕೆ, ವಿ ನೀಡ್ ಟು ನೋ ಸಮ್ ಅದರ್ ಪಾಯಿಂಟ್ಸ್ ರಿಲೇಟೆಡ್ ಟು ಆರ್ ಇಂಟ್ರೊಡಕ್ಷನ್ ರಿಲೇಟೆಡ್ ಟು ಕಾರ್ಸಿನೋಮಾ ಆಫ್ ಸ್ಟಮಕ್. ಸೊ ಇದರಲ್ಲೇನು ಮ್ಯಾಕ್ಸಿಮಮ್ ಇನ್ಸಿಡೆನ್ಸ್ ಆಫ್ ಕಾರ್ಸಿನೋಮಾ ಆಫ್ ಸ್ಟಮಕ್ ಈಸ್ ಯೂಶುವಲಿ ಸೀನ್ ಇನ್ ವಿಚ್ ಕಂಟ್ರಿ ಅಂದರೆ ಜಪಾನ್. ಓಕೆ, ಆ್ಯಂಡ್ ಇಟ್ ಈಸ್ ಮೋರ್ ಕಾಮನ್ ಇನ್ ಮೇಲ್ಸ್ ಆ್ಯಂಡ್ ಯೂಶುವಲಿ ಸೀನ್ ಡ್ಯೂರಿಂಗ್ 6th decade. ಮೋಸ್ಟ್ ಕಾಮನ್ ಸೈಟ್ ಎಲ್ಲಿಂದ ಬರುತ್ತೆ? ಇಟ್ ಈಸ್ ಫ್ರಮ್ ದ ಆ್ಯಂಟ್ರಮ್. ದಿಸ್ ವಿ ಹ್ಯಾಡ್ ಸ್ಟಡಿಡ್ ಯೆಸ್ಟರ್ಡೇ ಆಲ್ಸೋ. ಓಕೆ, ಆ್ಯಂಡ್ ಮೋಸ್ಟ್ ಕಾಮನ್ ಸೈಟ್ ಆಫ್ CS ಸ್ಟಮಕ್ ಇನ್ ಪರ್ನಿಷಿಯಸ್ ಅನಿಮಿಯಾ ಪೇಷಂಟ್ಸಲ್ಲಿ ಫಂಡಸ್. ಓಕೆ, ಮೋಸ್ಟ್ ಕಾಮನ್ ಸೈಟ್ ಆಫ್ ಮೆಟಾಸ್ಟಸಿಸ್ ಎಲ್ಲಿ ಈ CS ಸ್ಟಮಕ್ಕು ಎಲ್ಲಿಗೆ ಮೆಟಾಸ್ಟೈಸೈಸ್ ಆಗುತ್ತೆ ಅಂದರೆ ಲಿವರಿಗೆ. ಓಕೆ, ಸೊ ವಾಟ್ ಈಸ್ ದ ಕೆಮೊಥೆರಪಿ ರೆಜಿಮನ್ ವಿ ಫಾಲೋ ಇನ್ ಕೇಸ್ ಆಫ್ CS ಸ್ಟಮಕ್ ಅಂದರೆ ಇಟ್ ಇಸ್ ಸೇಮ್ ಆಸ್ ಈಸೋಫೆಗಸ್, ದಟ್ ಈಸ್ CEF ಅಥವಾ ECF ಹೆಂಗೆ ಬೇಕೋ ನೆನ್ಪಿಟ್ಕೊಳ್ಳಿ. ಎಪಿರುಬಿಸಿನ್, ಸಿಸ್ಪ್ಲಾಟಿನ್ ಆ್ಯಂಡ್ 5-fluorouracil. Okay, so these are the chemotherapy regimen we'll use. So most commonly seen in Japan and most common site is antrum. This we need to remember. Okay, after this, what are the risk factors for carcinoma of stomach? ಎಲ್ಲರಿಗೂ ಬರುತ್ತೆ. ಏನು ರಿಸ್ಕ್ ಫ್ಯಾಕ್ಟರ್ಸ್ ಏನಿರುತ್ತೆ, ಯಾರಿಗೆ ಬರುತ್ತೆ ಜಾಸ್ತಿ CS ಸ್ಟಮಕ್ ಅಂತ ಕೇಳಿದರೆ, ಯೂಶಲಿ ಯು ಕ್ಯಾನ್ ಡಿವೈಡ್ ಇಟ್ ಇಂಟು 6 boxes or 6 main factors, that is nutritional factors. Usually the people who consume low fat or low protein intake, they are at risk for developing CS stomach. Along with that, high complex carbohydrate intake, they are at risk for CS stomach. Increased nitrate intake, they are at risk for CS stomach. And those who consume salted meat, they can have CS stomach. Okay, then social factors, low socio-economic status alli usually we'll see. Okay, environmental causes ಏನೇನು, ಸ್ಮೋಕಿಂಗು, ಲ್ಯಾಕ್ ಆಫ್ ರೆಫ್ರಿಜರೇಷನ್, ಯೂಸ್ ಆಫ್ ವೆಲ್ ವಾಟರ್ ಆ್ಯಂಡ್ ಪುವರ್ ಫುಡ್ ಪ್ರಿಸರ್ವೇಷನ್ ಟೆಕ್ನಿಕ್, ಅನ್ಹೈಜಿನಿಕ್ ಟೆಕ್ನಿಕ್ಸು, ಅಲಾಂಗ್ ವಿತ್ ದಟ್ ಸ್ಮೋಕಿಂಗ್. ಓಕೆ, ಸೊ ವಾಟ್ ಆರ್ ದ ಮೆಡಿಕಲ್ ಫ್ಯಾಕ್ಟರ್ಸ್ ವಿಚ್ ಕ್ಯಾನ್ ಲೀಡ್ ಟು CS ಸ್ಟಮಕ್ ಅಂದರೆ, ಹಿಸ್ಟ್ರಿ ಆಫ್ ಪಾರ್ಷಿಯಲ್ ಗ್ಯಾಸ್ಟ್ರೆಕ್ಟಮಿ. ಆಲ್ರೆಡಿ ಏನೋ ಒಂದು ಗ್ಯಾಸ್ಟ್ರಿಕ್ ಅಲ್ಸರ್ ಏನೋ ಆಗಿದೆ, ಫಾರ್ ದ್ಯಾಟ್ ಹಿ ಹ್ಯಾಸ್ ಅಂಡರ್ಗಾನ್ ಪಾರ್ಷಿಯಲ್ ಗ್ಯಾಸ್ಟ್ರೆಕ್ಟಮಿ, ದೆನ್ ಹಿ ಈಸ್ ಅಟ್ ಎನ್ ಇನ್ಕ್ರೀಸ್ಡ್ ರಿಸ್ಕ್ ಫಾರ್ ಡೆವಲಪಿಂಗ್ CS ಸ್ಟಮಕ್. ಅದರ್ ದನ್ ದಟ್ H. pylori infection is a leading cause for gastric ulcer ಅಲ್ವಾ. ಸೊ ಬೇಸಿಕಲಿ ಗ್ಯಾಸ್ಟ್ರಿಕ್ ಅಲ್ಸರ್ wound, if it won't heal, it will lead for CS stomach ಅಷ್ಟೇ. ಈ ಥರ ನೆನ್ಪಿಟ್ಕೋಬೋದು. ಸೊ ಗ್ಯಾಸ್ಟ್ರಿಕ್ ಅಲ್ಸರ್ ಆಗಿದೆ, ಇಫ್ ಹಿ ಹ್ಯಾಸ್ ಆಲ್ರೆಡಿ ಅಂಡರ್ಗಾನ್ ಪಾರ್ಷಿಯಲ್ ಗ್ಯಾಸ್ಟ್ರೆಕ್ಟಮಿ, ಈವನ್ ದೆನ್ ಹಿ ಈಸ್ ಅಟ್ ರಿಸ್ಕ್. ಒಂದ್ಸಲ ಅಲ್ಸರ್ ಆಯಿತು ಅಂದರೆ ಹಿ ಈಸ್ ಅಟ್ ರಿಸ್ಕ್ ಅಂತ. ಅದರ್ ದನ್ ದಟ್ ಎನಿ ಅದರ್ ಇನ್ಫೆಕ್ಷನ್ಸ್ ಲೈಕ್ ಎಪ್ಸ್ಟೈನ್ ಬಾರ್ ವೈರಸ್ ಇನ್ಫೆಕ್ಷನ್ ಇರ್ಬೋದು. ದೆನ್ ಅಡಿನೋಮ್ಯಾಟಸ್ ಪಾಲಿಪ್, ಅಗೇನ್ ಅಲ್ಸರ್ ಏನೋ ಆಗಿದೆ, ಅಥವಾ there is some outgrowth, there is some pathology in the epithelium which can cause polyp, and again that polyp may become carcinoma. Other than that, chronic atrophic gastritis and Meniere's disease, all these are medical factors responsible for, or medical risk factors we can say, for CS stomach. Occupational, those who work in rubber and coal industries, they are at increased risk. Genetic factors being, males are more prone, blood group A is more prone, that is type 1 gastric ulcer ಆಗುತ್ತಲ್ಲ, blood group A. Then HNPCC, hereditary colorectal cancers, then Lee-Frommeni syndrome, pernicious anemia. All these factors, genetic factors, pose a risk for developing carcinoma of stomach. what we need to know is alcohol have no association with carcinoma of stomach. It is not a risk factor for carcinoma of stomach, whereas smoking is. Okay, so what are the protective factors? Risk factors ಗೊತ್ತಾಯಿತು. Protective factors ಏನೇನು? Iron, zinc, selenium, and usually aspirin, vitamin A, because antioxidants. Other than that, calcium and vitamin C, they are known to be protective factors for CA stomach. Okay, now again, where if it is a carcinoma, in order to simplify the pathology, or in order to simplify the study of treatment, we will classify the carcinomas. Okay, so first classification is Borman's classification. In this, we will classify carcinoma of stomach based on macroscopic appearance, how it will appear to naked eye. If the carcinoma or if the tumor is a diffuse polypoidal growth, so suppose it is like this, ಇಲ್ಲಿಂದ ಅರೈಸ್ ಆಗ್ತಾ ಇದೆ. If it is diffuse and polypoidal growth, then this is type 1. Okay, type 2, it is ulcerated lesion with raised or elevated border. So this is type 1, this is type 2. Okay, so type 3 is ulcerated lesion infiltrating the gastric wall. Type 4 is linitis plastica, that is a leather bottle appearance ತರ ಇರುತ್ತೆ. Okay, type 5 is, if not among the 4, then it is listed as type 5, ಅಷ್ಟೇ, non classifiable. So based on macroscopic appearance, how it appears to naked eye, Borman has classified the tumor. Okay, this is simple. Okay, next one more classification, that is Lawrence classification. Lawrence ಅನ್ನೋನು ಏನು ಮಾಡ್ತಾನೆ, he classified CA stomach into two types or two varieties. One is intestinal variety, other one is diffuse variety. Intestinal variety is classical variety, whereas diffuse variety is atypical. What is the difference now? Usually intestinal variety is most common in males and usually seen in the 5th to 6th decade. Most common site is distal part of the stomach. Environmental risk factors will be more, and it is well defined gland formation, proper adenocarcinoma. Usually hematogenous spread ಆಗುತ್ತೆ. ಏನಾಯಿತು? ಡೌಟ್ಸ್ ಇದ್ದರೆ ಕೇಳಿ. ಹಾಂ, ಯಾರೋ ಹ್ಯಾಂಡ್ ರೈಸ್ ಮಾಡಿದ್ರು, ಹಂಗೆ ಕೇಳಿದೆ. ಕಂಟಿನ್ಯೂ ಮಾಡ್ಬೋದಾ?
ಕಂಟಿನ್ಯೂ ಮಾಡೋಣ.
Okay, so we were dealing with Lawrence classification. It classifies the CA stomach into intestinal variety and diffuse variety. Intestinal variety is a classical, or diffuse variety is atypical. Intestinal variety is most common in males in 5th to 6th decade, and most common site is distal part. It is usually associated with environmental risk factors, and well defined gland formation is there. It is hematogenic, spread through hematogenous route. It is associated with a gene mutation called as APC gene mutation. Okay, and it is epidemic. Whereas diffuse variety of CA stomach, it is most common in females and young age group. Most common site ಇದರಲ್ಲಿ distal part, but ಇದರಲ್ಲಿ fundus or the proximal part of the stomach. ಅಲ್ಲಿ environmental risk factors common. Here it is familial risk factors, and there is poor gland formation, that is signet ring variety. Okay, then the most common route of spread is lymphatic or transmural spread, and diseased, that is here there is APC gene mutation, here there is decreased E cadherin, and it is an endemic. Okay, but both ಎರಡಕ್ಕೂ ಕಾಮನ್ ಇರೋದೇನೆಂದರೆ both are associated with P16 and P53 genes inactivation. ಬೇಸಿಕಲಿ ಇವೆರಡು ಜೀನ್ಸು ಆ್ಯಂಟಿ ಅಪೋಪ್ಟೋಟಿಕ್ ಏನಂತಾರೆ, ದೀಸ್ ಆರ್ ಆ್ಯಂಟಿ ಅಪೋಪ್ಟೋಟಿಕ್ ಜೀನ್ಸ್ ಅಂತ. ಅಪೋಪ್ಟೋಸಿಸ್ ಆಗೋದನ್ನು ತಪ್ಪಿಸ್ತಿರುತ್ತೆ. ಬಟ್ ಇವೆರಡು ಇನ್ಯಾಕ್ಟಿವೇಟ್ ಆಗೋದ್ರಿಂದ ಏನಾಗುತ್ತೆ, there will be no anti-apoptotic, so there will be more damage or more growth of the tumors. Okay, or you can say tumor suppressor genes. ಇವೆಲ್ಲ ಟ್ಯೂಮರ್ ಸಪ್ರೆಸರ್ ಜೀನ್ಸ್ ಏನು ಮಾಡ್ತಿರುತ್ತೆ, ಟ್ಯೂಮರ್ ಗ್ರೋತ್ ಆಗೋದನ್ನು ಸಪ್ರೆಸ್ ಮಾಡ್ತಿರುತ್ತೆ. ಸೊ ಈ ಕೇಸಲ್ಲಿ ಏನಾಗುತ್ತೆ, ದೀಸ್ P16 and P53 will be inactivated, because of which there will be no tumor suppression and tumor will start growing. ಓಕೆನಾ? ಟ್ಯೂಮರ್ ಸಪ್ರೆಸರ್ ಜೀನ್ಸ್. So after knowing Lawrence classification and Borman's classification, we'll go for clinical features. How will the patient present in case of a carcinoma of stomach? Most common symptom will be as usual abdominal pain. Other than that, ಕ್ಯಾನ್ಸರ್ ಅಥವಾ ಕಾರ್ಸಿನೋಮಾದ ಮೋಸ್ಟ್ ಕಾಮನ್ ಫೀಚರ್ ಏನು ವೆಯ್ಟ್ ಲಾಸು ಲಾಸ್ ಆಫ್ ಅಪೆಟೈಟು ಫೆಟೀಗು ಇವೆಲ್ಲ ಇದು ಇರುತ್ತೆ. ಆ್ಯಂಡ್ ದೆನ್ ಇಫ್ ದ ಟ್ಯೂಮರ್ ಈಸ್ ಇನ್ ಗ್ಯಾಸ್ಟ್ರೋಇಸೋಫೇಜಿಯಲ್ ಜಂಕ್ಷನ್, ಮೋಸ್ಟ್ ಕಾಮನ್ ಸಿಂಪ್ಟಮ್ ವಿಲ್ ಬಿ ಡಿಸ್ಫೇಜಿಯಾ. ಓಕೆ, ಸೊ ನಾವು ಗ್ಯಾಸ್ಟ್ರೋಇಸೋಫೇಜಿಯಲ್ ಜಂಕ್ಷನ್ ಟ್ಯೂಮರ್ಗೆ ಇನ್ನೊಬ್ಬ ಸೈಂಟಿಸ್ಟ್ ಬಂದು ಕ್ಲಾಸಿಫಿಕೇಶನ್ ಕೊಟ್ಟ, ದಟ್ ಈಸ್ ಸೀವರ್ಡ್ ಕ್ಲಾಸಿಫಿಕೇಶನ್. ಇದರಲ್ಲೇನು ಬೇಸ್ಡ್ ಆನ್ ದ ಲೊಕೇಶನ್ ಫ್ರಮ್ ದ ಗ್ಯಾಸ್ಟ್ರೋಇಸೋಫೇಜಿಯಲ್ ಜಂಕ್ಷನ್. ಇವಾಗ ಗ್ಯಾಸ್ಟ್ರೋಇಸೋಫೇಜಿಯಲ್ ಜಂಕ್ಷನ್ ಇಲ್ಲಿದೆ, ಓಕೆನಾ. ಇಫ್ ಟೈಪ್ 1 ದಟ್ ಈಸ್ ಅಬೋವ್ ದ ಗ್ಯಾಸ್ಟ್ರೋಇಸೋಫೇಜಿಯಲ್ ಜಂಕ್ಷನ್ 1 to 5 centimeter ಇದ್ದರೆ, ದಟ್ ಈಸ್ ಇನ್ವಾಲ್ವಿಂಗ್ ಡಿಸ್ಟಲ್ ಈಸೋಫೆಗಸ್, then that is adenocarcinoma of distal esophagus. If 1 centimeter above and 2 centimeter of below the cardia in the tumor ಬರ್ತಾ ಇದ್ರೆ, that is type 2 and that is actually real cardia. If it is 2 to 5 centimeter below the cardia, then that is subcardial stomach, and that classification, that tumor is grouped under type 3 Seward classification. Okay, now this will help in identifying whether it is type 1 or type 2 or type 3, and based on that we can identify if it is distal esophagus or cardia or subcardial stomach. Okay na. So ನೆಕ್ಸ್ಟ್ ಅವಾಗಲೇ ಹೇಳಿದ್ನಲ್ಲ ಲಿನಿಟಸ್ ಪ್ಲಾಸ್ಟಿಕಾ ಅಂತ, ಲೆದರ್ ಬಾಟಲ್ ಥರ, ಲೆದರ್ ಬಾಟಲ್ ಸ್ಟಮಕ್ ಅಂತ ಹೆಂಗೆ ಕಾಣಿಸುತ್ತೆ ಅಂದರೆ ಈ ಥರ, ಬೇಸಿಕಲಿ ಲೈಕ್ ಅ ಲೆದರ್ ಬಾಟಲ್, ದಿಸ್ ಲೈಕ್ ದಿಸ್ ಲೆದರ್ ಬಾಟಲ್ ಅಪಿಯರೆನ್ಸ್. ಓಕೆ, it is characterized by diffuse proliferation of fibrous tissue, and the most common symptom is early satiety. Okay, so there is a lymph node involvement in case of CS stomach, because lymphatic spread ಕೂಡ ಆಗುತ್ತೆ in case of diffuse variety of CS stomach. ಸೊ ಈ lymphatic involvement ಹೆಂಗಾಗುತ್ತೆ ಅಂದರೆ, we need to know about the lymphatic drainage of stomach. ಅನಾಟಮಿಯಲ್ಲಿ ಓದಿರ್ತೀವಿ. ಸೊ ಸ್ಟೊಮಕ್ lymphatic drainage happens to most of the nodes, like axillary nodes ಆಗುತ್ತೆ ಆಯಿತಾ. ಅದಾದಮೇಲೆ ಲೆಫ್ಟ್ ಸುಪ್ರಾಕ್ಲಾವಿಕ್ಯುಲರ್ ನೋಡ್ಸಿಗೆ ಆಗುತ್ತೆ. ಅದಾದಮೇಲೆ ಪೆರಿಟೋನಿಯಲ್, ರೆಟ್ರೋಪೆರಿಟೋನಿಯಲ್ ಲಿಂಫ್ ನೋಡ್ಸಿಗೆ ಆಗುತ್ತೆ. ಸೊ ಬೇಸ್ಡ್ ಆನ್ ದ್ಯಾಟ್ ದೇರ್ ಕ್ಯಾನ್ ಬಿ ಇನ್ವಾಲ್ವ್ಮೆಂಟ್ ಆಫ್ ದೋಸ್ ನೋಟ್ಸ್ ಆಲ್ಸೋ, ಆ್ಯಂಡ್ ಇಫ್ ದೋಸ್ ನೋಟ್ಸ್ ಆರ್ ಇನ್ವಾಲ್ವ್ಡ್ ದೇ ವಿಲ್ ಗಿವ್ ಸ್ಪೆಸಿಫಿಕ್ ಅಪಿಯರೆನ್ಸ್ ಆ್ಯಂಡ್ ದ್ಯಾಟ್ ಈಸ್ ಲೇಬಲ್ಡ್. ಓಕೆನಾ. if there is involvement of axillary lymph nodes, then it is called as iris nodes. Okay na. If there is involvement of left supraclavicular lymph node, then the left supraclavicular lymph node will be enlarged, and that is called as Virchow's node, and this sign is called as Stroizier's sign. Basically the patient will be coming with complaints of abdominal pain, and you try to examine the patient. You will ask him to expose the anterior abdominal wall, and incidentally you will be able to see an enlarged left supraclavicular lymph node. So this is a sign by which you can diagnose CS stomach also. If you see this Virchow's node or Stroizier's sign, this is a sign for CS stomach. So you can go and proceed in the direction of CS stomach. Okay. So cutaneous metastatic deposits around the umbilicus, which is called as Sister Mary Joseph nodes. ಬೇಸಿಕಲಿ ಆಂಟೀರಿಯರ್ ಅಬ್ಡಾಮಿನಲ್ ವಾಲ್ ಹಿಂಗಿದೆ ಅಂದರೆ ಅಂಬಲಿಕಸ್ಸು, ಇದ್ರ ಸುತ್ತ ದೇರ್ ಕ್ಯಾನ್ ಬಿ ಅಪಿಯರೆನ್ಸ್ ಲೈಕ್ ಅ ಮಾಸ್ ಆರ್ ಲೈಕ್ ಅ ಮೆಟಾಸ್ಟಾಟಿಕ್ ಡೆಪಾಸಿಟ್ಸ್ ಅರೌಂಡ್ ದ ಅಂಬಲಿಕಸ್. ಸೊ ದಿಸ್ ವಾಸ್ ಪ್ರೈಮರಿಲಿ ಸೀನ್ ಬೈ ಅ ಸಿಸ್ಟರ್ ಮೇರಿ, ಆಯಿತಾ. ಸೊ ಒಬ್ಬಳು ಡಾಕ್ಟ್ರ್ ಹತ್ರ ಕೆಲಸ ಮಾಡ್ತಿಲ್ಲಂತ ಈ ಸಿಸ್ಟರ್ ಮೇರಿ. CS ಸ್ಟಮಕ್ ಪೇಷಂಟ್ಸ್ ಬಂದಾಗೆಲ್ಲ ಅವರು ಅಬ್ಸರ್ವ್ ಮಾಡಿದರೆ, ಒಂದಷ್ಟು ಕೇಸಸ್ ಅಬ್ಸರ್ವ್ ಮಾಡಿದರೆ CS ಸ್ಟಮಕ್ಕಿಗೂ ಇದಕ್ಕೂ ಏನೋ ಅಸೋಸಿಯೇಷನ್ ಇದೆ ಸರ್ ಅಂತ ಡಾಕ್ಟ್ರಿಗೆ ಹೇಳಿದ್ದಾರೆ. ಆಮೇಲೆ ಅವರಿಬ್ಬರು ಸೇರಿಕೊಂಡು ದೇ ಹ್ಯಾವ್ ಐಡೆಂಟಿಫೈಡ್ ದಿಸ್ ಸಿಸ್ಟರ್ ಮೇರಿ ಜೋಸೆಫ್ ನೋಟ್ಸ್ ಈಸ್ ಲಿಂಕ್ಡ್ ವಿತ್ CS ಸ್ಟಮಕ್. ಓಕೆನಾ. ಹೆನ್ಸ್ ದ ನೇಮ್ ಸಿಸ್ಟರ್ ಮೇರಿ ಜೋಸೆಫ್ ನೋಟ್ಸ್. ಸೊ other than that, if there is palpable intraperitoneal metastasis on digital rectal examination, then that is called as Blummer's shelf. So parectal or digital rectal examination ಮಾಡ್ತೀರಾ, ಆವಾಗ if you are able to feel or if you are able to palpate intraperitoneal lymph nodes, then that is called as Blummer's shelf. Okay. In case of a female patient, the CS stomach lymphatic drainage can reach the bilateral ovary, and that is called as Krukenberg's tumor. Okay. So retrograde lymphatic spread is the most common, and it hematogenous route ಅಲ್ಲೂ ಆಗುತ್ತೆ, ಟ್ರಾನ್ಸ್ಇಲೋಮಿಕ್ ಆರ್ ಟ್ರಾನ್ಸ್ಪೆರಿಟೋನಿಯಲ್ ರೂಟಲ್ಲಿ ಬೇಕಾದ್ರೆ ಆಗ್ಬೋದು. ಈ ಮೂರು ರೂಟಲ್ಲಿ ಯಾವುದೋ ಒಂದು ರೂಟಲ್ಲಿ ಇಫ್ ದ tumor cells from the stomach is reaching the ovary, then that tumor is called as Krukenberg tumor. Okay, so after this, how will we diagnose CS stomach? CS stomach diagnosis ಹೆಂಗೆ ಮಾಡ್ತೀವಿ, ಬೇಸಿಕಲಿ ಎಂಡೋಸ್ಕೋಪಿ ಮಾಡ್ತೀವಿ, ಆ್ಯಂಡ್ ಇನ್ ಆರ್ಡರ್ ಟು ಸ್ಟೇಜ್ ಇಟ್ ವಿಲ್ ಗೋ ಫಾರ್ ಬಯೋಪ್ಸಿ. ಓಕೆ, ಸೊ ಇನ್ವೆಸ್ಟಿಗೇಷನ್ ಆಫ್ ಚಾಯ್ಸ್ ಫಾರ್ ಸ್ಟೇಜಿಂಗ್ ಈಸ್ ಎಂಡೋಸ್ಕೋಪಿಕ್ ಅಲ್ಟ್ರಾಸೌಂಡ್. Okay, so what is the best investigation for pre-operative staging? It is contrast enhanced CT. That's the mic on agide ನೋಡಿ. Okay, so based on this we will go for TNM staging of the stomach, CS stomach. Correct? So TNM staging ಅಂದ್ರೆ basically this will help in treating the carcinoma of the stomach. So if the tumor is in situ, that is just high grade dysplasia, ಅದೇ ರೀಜನಲ್ಲಿದೆ, it is just dysplasia, then that is carcinoma in situ. T1A ಅಂದರೆ ಟ್ಯೂಮರ್ ಇನ್ವೇಡ್ಸ್ ದ lamina propria or muscularis mucosa of the stomach. T1B ಅಂದರೆ ಟ್ಯೂಮರ್ ಇನ್ವೇಡ್ಸ್ submucosa. After that T2 it invades muscularis propria. So basically layers of the stomach ಗೊತ್ತಿದ್ರೆ TNM staging is easy. T3 tumor penetrates subserosal connective tissue without invading the visceral peritoneum or the adjacent structures. If it involves visceral peritoneum, then T4A. If it involves adjacent structures, then that is T4B. Okay na? So basically it will start from lamina propria and end in adjacent structures. Lymph nodes ಅಷ್ಟೇ, 1 or 2 lymph nodes ಅಷ್ಟೇ ಇನ್ವಾಲ್ವ್ ಆಗಿದ್ರೆ it is N1, 3 to 6 ಆಗಿದ್ರೆ it is N2, 7 to 15 ಆಗಿದ್ರೆ it is N3, N3A, more than 16 ಆಗಿದ್ರೆ N3B. ಓಕೆನಾ? ಮೆಟಾಸ್ಟಾಸಿಸ್ ಇಲ್ಲ ಅಂದರೆ M0, ಮೆಟಾಸ್ಟಾಸಿಸ್ ಇದ್ದರೆ M1. ಬೇಸ್ಡ್ ಆನ್ ದಿಸ್ ವಿಲ್ ಡಿಸೈಡ್ ದ ಟ್ರೀಟ್ಮೆಂಟ್. ಇಟ್ ಈಸ್ ಡಿಪೆಂಡಿಂಗ್ ಅಪಾನ್ ದ ಲೊಕೇಶನ್ ಆಫ್ ದ ಮ್ಯಾಲಿಗ್ನೆನ್ಸಿ. ಸೊ ಇಫ್ ದ ಲೊಕೇಶನ್ ಈಸ್ ಇನ್ ದ ಪ್ರಾಕ್ಸಿಮಲ್ 1/3 ಆಫ್ ದ ಸ್ಟಮಕ್, ದಟ್ ಈಸ್ ಕಾರ್ಡಿಯಾ ಆರ್ ಫಂಡಸ್ ರೀಜನ್, ವಿಲ್ ಹ್ಯಾವ್ ಟು ಗೋ ಫಾರ್ ಎಕ್ಸ್ಟೆಂಡೆಡ್ ಗ್ಯಾಸ್ಟ್ರೆಕ್ಟಮಿ ಆ್ಯಂಡ್ D2 ಲಿಂಫೆಡಿನೆಕ್ಟಮಿ. ಆಯಿತಾ? ಎಕ್ಸ್ಟೆಂಡೆಡ್ ಗ್ಯಾಸ್ಟ್ರೆಕ್ಟಮಿ ಮಾಡಿ D2 ಲಿಂಫೆಡಿನೆಕ್ಟಮಿ ಮಾಡ್ತೀವಿ. ಮಿಡಲ್ 1/3 ಅಂದರೆ ಆ್ಯಂಟ್ರಮ್ ರೀಜನ್ವರೆಗೂ ಬಂದಿದೆ ಅಂತ ಅಂದ್ಕೊಳ್ಳಿ, ಆವಾಗ ಟೋಟಲಾಗಿ ಗ್ಯಾಸ್ಟ್ರೆಕ್ಟಮಿ ಮಾಡಬೇಕಾಗುತ್ತೆ. ಅದರ ಜೊತೆಗೆ D2 ಲಿಂಫ್ ನೋಟ್ಸ್ನ ರಿಮೂವ್ ಮಾಡಬೇಕಾಗುತ್ತೆ. ಡಿಸ್ಟಲ್ 1/3 ಅಂದರೆ ಆಲ್ಮೋಸ್ಟ್ ಪೈಲೋರಸ್ವರೆಗೂ ಬಂದಿದೆ ಅಂತಂದರೆ ದೆನ್ ವಿಲ್ ಹ್ಯಾವ್ ಟು ಗೋ ಫಾರ್ ಸಬ್ ಟೋಟಲ್ ಗ್ಯಾಸ್ಟ್ರೆಕ್ಟಮಿ, ಅಂದರೆ 90% ಆಫ್ ದ ಸ್ಟಮಕ್ ಈಸ್ ರಿಮೂವ್ಡ್, ಅಲಾಂಗ್ ವಿತ್ ದಟ್ D2 ಲಿಂಫೆಡಿನೆಕ್ಟಮಿ ಈಸ್ ಡನ್. ಸೊ ದಿಸ್ ಟ್ರೀಟ್ಮೆಂಟ್ ಈಸ್ ಸೇಮ್ ಫಾರ್ ಬೋತ್ ಇಂಟೆಸ್ಟೈನಲ್ ಆ್ಯಂಡ್ ಡಿಫ್ಯೂಸ್ ವೆರೈಟಿ. ಆಯಿತಾ? ಡಿಫ್ಯೂಸ್ ವೆರೈಟಿ ಇನ್ವಾಲ್ವಿಂಗ್ ಡಿಸ್ಟಲ್ 1/3 ಆಫ್ ಮ್ಯಾಲಿಗ್ನೆನ್ಸಿ, then we'll have to go for total gastrectomy and D2. Usually ನಾನು ಹೇಳಿದ್ನಲ್ವಾ, ಡಿಫ್ಯೂಸ್ ವೆರೈಟಿ ಇಟ್ ವಿಲ್ ಇನ್ವಾಲ್ವ್ ಪ್ರಾಕ್ಸಿಮಲ್ ರೀಜನ್, ಮೋಸ್ಟ್ ಕಾಮನ್ಲಿ ಪ್ರಾಕ್ಸಿಮಲ್ ಪಾರ್ಟ್. ಬಟ್ ಇಫ್ ಇಟ್ ಇನ್ವಾಲ್ವ್ಸ್ ಡಿಸ್ಟಲ್ ಪಾರ್ಟ್, ದೆನ್ ವಿಲ್ ಹ್ಯಾವ್ ಟು ಗೋ ಫಾರ್ ಟೋಟಲ್ ಗ್ಯಾಸ್ಟ್ರೆಕ್ಟಮಿ. ಬಟ್ ಇದರಲ್ಲಿ ಏನು ಮಾಡ್ತೀವಿ, ಯೂಶಲಿ ಡಿಸ್ಟಲ್ 1/3 ಇದ್ದರೆ ಬರೀ ಸಬ್ ಟೋಟಲ್ ಮಾಡ್ತಿದ್ವಿ. ಬಟ್ ಇಫ್ ಇಟ್ ಈಸ್ ಅ ಡಿಫ್ಯೂಸ್ ವೆರೈಟಿ, ದೆನ್ ವಿಲ್ ಹ್ಯಾವ್ ಟು ಗೋ ಫಾರ್ ಟೋಟಲ್ ಗ್ಯಾಸ್ಟ್ರೆಕ್ಟಮಿ. ಸೊ ಇಂಡಿಕೇಶನ್ ಫಾರ್ ಡಿಸ್ಟಲ್ ಪ್ಯಾಂಕ್ರಿಯಾಟೆಕ್ಟಮಿ, ಯಾವಾಗ ಪ್ಯಾಂಕ್ರಿಯಾಸ್ನು ರಿಮೂವ್ ಮಾಡಬೇಕಾಗುತ್ತೆ ಅಂದರೆ ಇಫ್ ದೆರ್ ಈಸ್ ಇನ್ವಾಲ್ವ್ಮೆಂಟ್ ಆಫ್ ಬಾಡಿ ಆರ್ ಟೈಲ್ ಆಫ್ ದ ಪ್ಯಾಂಕ್ರಿಯಾಸ್ ಬೈ ದ ಟ್ಯೂಮರ್, ಬಿಕಾಸ್ ವಿ ಆಲ್ ನೋ ಪ್ಯಾಂಕ್ರಿಯಾಸ್ ಲೈಸ್ ಇನ್ ದ C shape ಆಫ್ ದ ಡುಯೋಡೆನಮ್ ಲೈಕ್ ದಿಸ್. ಇವಾಗ ಇಲ್ಲಿಂದ ಟ್ಯೂಮರ್ ಅರೈಸ್ ಆಗಿ ಇಫ್ ಇಟ್ ಈಸ್ ಇನ್ವಾಲ್ವಿಂಗ್ ದ ಬಾಡಿ ಆರ್ ಟೈಲ್ ಆಫ್ ದ ಪ್ಯಾಂಕ್ರಿಯಾಸ್, ದೆನ್ ವಿಲ್ ಹ್ಯಾವ್ ಟು ಗೋ ಫಾರ್ ಡಿಸ್ಟಲ್ ಪ್ಯಾಂಕ್ರಿಯಾಟೆಕ್ಟಮಿ ಆಲ್ಸೋ. ಓಕೆ, ಸ್ಪ್ಲೀನೆಕ್ಟಮಿ, direct involvement of spleen by CS stomach, or if the CS stomach in the proximal part along the posterior wall or greater curvature. So basically spleen tail ಅಂದರೆ pancreas tail ಹೋಗಿ spleen ಹತ್ರ ಇರುತ್ತೆ. So if this is involving spleen, then we'll have to go for splenectomy also. So prognostic factors ಏನು, based on the depth of invasion, ಎಷ್ಟು ಡೆಪ್ತ್ ಆಗಿದೆ ಟ್ಯೂಮರ್ ಅನ್ನೋದ್ರ ಮೇಲೆ, ಆ್ಯಂಡ್ ಲಿಂಫ್ ನೋಡ್ ಸ್ಟೇಟಸ್, N1 N2 N3 ಇದು ಸಿಂಗಲ್ ಮೋಸ್ಟ್ ಪ್ರೋಗ್ನೋಸ್ಟಿಕ್ ಫ್ಯಾಕ್ಟರ್ ಆಗುತ್ತೆ. Lesser the number of lymph nodes involved, good the prognosis ಅಷ್ಟೆ. ಸೊ ದಿಸ್ ವಾಸ್ ಅಬೌಟ್ CS stomach. ಇವತ್ತಿಗೆ ಸಾಕಾ ಅಥವಾ ಕಂಟಿನ್ಯೂ ಮಾಡಿಬಿಡ್ಲಾ? ಇನ್ನೂ ತುಂಬ ಇದೆ. ಎಂಡ್ ಮಾಡೋಣ ಇವತ್ತಿಗೆ.